We will now study the medial aspect of the knee. I suggest that we start by reviewing a few anatomical concepts. An ultrasound examination of the knee is based on simple anatomical landmarks. First, the bone landmarks. On the femoral side, you can see the relatively large bony prominence of the medial epicondyle, and on the tibial side, under the posterior portion of the tibial plateau, you can see a groove where the anterior arm of the semimembranous tendon inserts. At the joint line, we can see the entire periphery of the medial meniscus. The medial collateral ligament has two components. The deep and fairly thin component corresponds to capsular thickening that adheres firmly to the medial meniscus and divides into two parts: the meniscofemoral ligament above and the meniscotibial ligament below. The superficial portion covers the deep one. It is thicker and much important biomechanically. This superficial portion is very broad. It inserts above on the medial epicondyle and slightly behind it. It descends in a straight line, crossing over the joint line, where it can be up to 20 mm wide, and partially inserts 1 cm below the plateau, but mostly lower, 6 to 8 cm below the joint line, on the medial side of the tibia. The anterior arm of the distal semimembranous tendon is also located on the medial side of the knee. The semimembranous muscle itself is posterior in the thigh. It's one of the hamstring muscles. Its distal tendon is complex, as it splits up into 5 major extensions. The most anterior arm, also called the pars reflexa, has an early horizontal trajectory along the bony tibial groove mentioned earlier, where it's covered by the medial collateral ligament. We end with the pes anserinus, a term that groups the tendons of 3 muscles that we can remember with the mnemonic say grace before T: the sartorius in front, the gracilis in the middle, and the semitendinosus in back. In fact, we can see on this highly simplified drawing that the muscles at the proximal end of the tendons are actually in front-to-back configuration, taking a vertical oblique trajectory of about 30 degrees forward, but at the level of the superior tibial metaphysis, they angle about 60 degrees to become nearly horizontal, where they insert on the anterior medial side of the tibia, very close to the tibial tuberosity. Just before their insertion, they cover the distal portion of the medial collateral ligament. To analyze the medial aspect of the knee, the patient can remain supine, but with the leg externally rotated like this. Personally, I prefer to have the patients lie on their side, which allows me to explore further back towards the popliteal fossa, and especially to go back up the pes anserinus. We start the examination of the medial aspect of the knee by positioning the probe to generate a coronal view at the joint line. It's easy to locate the meniscus as it has a triangular hyperechoic shape with a regular outline. I'd like to remind you that the free end of the meniscus is deep and can never be fully examined using ultrasound. Any suspected meniscal tear must always be confirmed with an MRI. Nevertheless, you can see here that the periphery of the meniscus is clearly visible. If we freeze the image here, we can trace a line between the cortex of the tibia and the femur. If the periphery of the meniscus extends past this tangent line by more than 3 mm, this is called meniscal extrusion, which is a fairly reliable sign of knee osteoarthritis. Similarly, at the articular surface, we are looking for potential osteophytes on the bone edges, even though we should, of course, already have looked for these on radiographs. We can now slide across the meniscus from front to back, from its anterior horn, its middle portion, and towards the back, looking for any tears or cysts. Now we are at the back, at the posterior part of the posterior horn of the medial meniscus. In the context of a knee injury, this is the time to look for any meniscocapsular separation at the level of this rump. Along its entire periphery, the meniscus must be really attached to the joint capsule. If we find a small quantity of fluid here, behind the periphery of the meniscus, this is a good reason to suspect meniscocapsular separation. The articular recesses, meniscotibial and meniscofemoral, are very small in a normal knee, containing only a few drops of fluid. They are easier to make out and can be filled a bit more if we unlock the knee. Flexing the knee slightly unlocks the collateral ligament and allows the recess to fill more easily. If there's a meniscus injury, this is where we look for potential displaced meniscal fragments, either here in the meniscotibial recess or higher in the meniscofemoral recess. The medial meniscus can also be examined in the transverse plane, even if it's slightly less informative. We rotate the probe 90 degrees. Above, we are here on the femoral cortex. Once we slide the probe downward, we're in the meniscus plane, which appears relatively hypoechoic. Then we go even lower down the tibial plateau plane. This view is less informative, but it can sometimes be an elegant way to show small calcium deposits inside the meniscus, and, if there is a cyst, to more easily show the tears that are feeding it. We will now examine the medial collateral ligament, which has two components. Its deep portion is firmly attached to the medial meniscus. It is formed by a meniscotibial ligament, which we can clearly see here, and a meniscofemoral ligament, which is very thin and firmly attached to the meniscus. The latter may be difficult to discern when normal. They are easy to see after a knee sprain since they are generally thickened. The superficial portion of the medial collateral ligament is much thicker than its deep portion, very fibrillar and hyperechoic when normal. It inserts above on the medial epicondyle and slightly behind it where it is relatively thick. Starting at this point, on a coronal view, we can slide the probe over the entire length of the ligament, which, you will see, continues very far down, below the medial tibial plateau. Here we go, continuing downward. You can see that the ligament always covers one or here two small arteries, the medial inferior knee arteries, which separate the ligament from the cortex. We have to continue down to find the distal insertion of this medial collateral ligament. Now we will scan the medial collateral ligament in the transverse plane. Rotating the probe 90 degrees, we start from its insertion high on the medial epicondyle. We clearly see that this ligament, unlike the lateral one, is actually a fairly long band that is 10 to 20 millimeters wide from front to back, depending on which plane we are on. It passes over the joint line, and we can then play with the anisotropy a bit at its lower portion where it's thinner to follow it until it inserts on the tibia. Here you can see the medial collateral ligament, and above that it is covered by tendon structures that go from back to front, 1, 2, and 3, which correspond to the tendons of the pes anserinus, which we will look at more in detail shortly. We have reached the end of the medial collateral ligament. If I go back to a coronal view, we are on its insertion. In the context of suspected medial collateral ligament sprains, we can use a dynamic maneuver to differentiate between grade 2, where the ligament is still continuous, and grade 3, where it is actually torn. This is the valgus stress test that clinicians know well. To do it, the knee must be unlocked, so place a bolster or rolled towel, whatever you want, to flex the knee slightly and unlock it. We then place a second bolster between the patient's legs to wedge the 2 feet apart like this, which provides some counter pressure. With my free hand, I press on the lateral side of the knee and analyze the collateral ligament on a coronal view as usual. The patient will need to counter my pressure by pressing firmly with the other foot. Now we go back to a coronal view of the medial collateral ligament and aim to look at our medial tibial plateau while sliding the probe towards the back. We will reach a small bone depression that contains an hyperechoic oval formation under the medial collateral ligament. This is the anterior arm of the distal semimembranous tendon. If we continue towards the back, we can see that it quickly merges into the direct arm of the semimembranosus tendon, which is seen in its long axis since it has a downward direction. And here, the fibers of the anterior arm of the tendon will gradually disappear. The anterior arm of the semimembranosus tendon can also be seen on an actual view starting at its tendon origin, the distal tendon of the semimembranosus. Here is the muscle in the upper part of the popliteal fossa. We descend along this distal tendon while playing with the anisotropy. Once we pass the joint line, we can see from these distal tendon fibers that become the direct arm that fibers branch out to take an horizontal long axis and insert on the medial tibial plateau at its mainly posterior aspect. Here we play with the anisotropy a bit to bring out the fibers of the anterior tendon arm in a posterior-anterior direction. We can restart in a coronal view in this area of the anterior arm of the semimembranosus tendon. If we flex the knee slightly to unlock it, we can sometimes see a small bursa, the bursa of the semimembranosus, which is arranged in an inverted U shape between the medial collateral ligament superficially and the tendon more deeply. This can be enlarged by bursitis. We will end the examination of the medial aspect of the knee with the famous pes anserinus, whose name reflects its similarity to the shape of the goose's foot. This is the end point of three muscles, the sartorius, gracilis and semitendinosus. It's true that it can be hard to find with ultrasound. Although it's very superficial, it's very thin, and its orientation is somewhat unique because of its angle at the distal end. To get oriented, let's start by sliding the probe along what we know best. What is easiest to find is the tendon of the semitendinosus, which is the cherry on top of the semimembranosus sundae. So here is the semitendinosus tendon. I found it fairly high in the popliteal fossa. If we shift this tendon to the side of our image, we can see, a bit towards the inside, a smaller tendon that corresponds to the gracilis tendon, and, as we shift then forward, a formation that is still muscular, which corresponds to the sartorius, the muscle portion of which is the lowest. If we continue down along the semitendinosus tendon, the semimembranosus comes in between, the gracilis, and here the sartorius. If I freeze the image, you can see here the position of my probe at the popliteal fossa, which is medial, gently angled down and back, perpendicular to our three tendons, which, of course, are oriented towards the front. Starting at this probe position, let's follow the pes anserinus tendons one by one, starting with the semitendinosus. We go down and forward while staying perpendicular to the axis of our tendon. You can see that it is still in the short axis. I go down without changing the angle of my probe. You can see that the fibers are now practically horizontal towards the front here and cover the medial collateral ligament, which is practically at its insertion. If we continue forward, here is the end of the semitendinosus tendon, which inserts on the anterior medial cortex of the tibia and is fairly close to the anterior tibial tuberosity, which is hidden here. Turn your knee slightly to back. And now we are virtually on the tibial tuberosity. We can do the same thing with the other tendons. If I bring the probe back to the popliteal fossa, we can identify the gracilis tendon again here. I follow along the gracilis in its short axis, and there again, the orientation changes. Oops, it's my probe that's not exactly in the correct plane. Here is the gracilis tendon in its short axis. We go down, down towards the front, and here are the fibers, which became horizontal and will insert themselves in the front, again on the anteromedial cortex of the tibia. The last one is the sartorius. Here, a muscle that goes relatively low, which wraps around the medial collateral ligament, and the tendon fibers here, we go down, and the fibers, which are relatively thick in principle, and here again will orient themselves towards the front. You should see the position of my probe practically in the same axis, but here the end of the tendon is seen in its long axis, we could say. I would like to emphasize the close relationship between the end of the medial collateral ligament and the end of the pes anserinus tendons. You can see how close they are, where the pes anserinus tendons are horizontal. They are there separated from the tibial cortex by the distal end of the medial collateral ligament in this location. We can rotate the probe 90 degrees to get a clearer picture of it. Here we find the medial collateral ligament, the arteries that we mentioned before, the ligament insertion, and if we look closely near the surface, we can make out these oval structures with the lower two being more or less coalescent. Here above the sartorius, since given the angulation, the tendon that was the most anterior, the sartorius, becomes superior, the gracilis stays in the middle, and the tendon that was the most posterior becomes inferior. This is the semitendinosus. Here, they are located above the medial collateral ligament. If we shift the probe towards the front, we leave the medial collateral ligament and arrive on the insertion of the pes anserinus tendon here. If I continue to slide it towards the front, we arrive at the anterior tibial tuberosity, which you can find here. Thus, their insertion is truly anteromedial, which means they participate not only in flexion, but also internal rotation of the knee. You have seen how the examination of the medial side of the knee is relatively simple when it comes to the small articular recesses, the medial meniscus, the medial collateral ligament, and the anterior arm of the semimembranosus tendon. It's a bit more complicated to examine the pes anserinus tendons, but with very specific and well-known anatomical landmarks, it's fairly easy to complete. So now it's your turn.